Welcome, everybody. Thank you for joining us today. My name is Dini Arsono. I work at CIRA, the Center for Interdisciplinary Research on AIDS at Yale University. And this is one of our CIRA talk presentation. So today's seminar is being recorded, and the slides and recording will be available at CIRA website. If you are new to CIRA, I would recommend visiting the CIRA website, the cira.yale.edu. We have a lot of information about upcoming events, archive recordings, and many of our activities and programs, services available to our affiliates. And I would also recommend to sign up to CIRA e-Bulletin, which is a bi-weekly newsletter that CIRA circulates. It is open to the public, and we have so many information about upcoming events and program through that e-Bulletin. Apologies for this. And so I'm just going to say a couple of quick things about upcoming events. So we have our CIRA Qualitative Research Discussion Group on November 19th, and also the next CIRA talk in December as well on December 14th. And I will post this bit.ly link on the chat that you can check out. And a couple of the QRDG event, you don't have to register to attend, but the CIRA talk in December, please register if you are interested in attending. And we also working on a listing of upcoming World AIDS Day event that we will be posted, that we will post on the CIRA website and also the CIRA e-Bulletin. So more to come on that. So today's agenda will include a presentation by our presenters, and then followed by discussion with a couple of our guest discussants. And there will be time for Q&A session with the seminar audience. So, and I would invite you to please use the chat to submit questions, comments, feedback, and engage with other participants. And we will monitor and try to respond to any questions that are coming up. But if we run out of time, I will save the chat file and then send to the speakers for follow-up on a later date. And with that, I will introduce Dr. Jennifer Edelman, who will moderate and facilitate the discussion today. She is at the Yale School of Medicine, School of Public Health, and she's the director of the Clinical and Health Services Research Core at CIRA. Jen?
Thank you, Dini and Pete, for all your efforts to organize us, and so excited about the presentation and being here with you all. Thank you so much. Dr. Luke Davis, we're thrilled to hear about your work. Dr. Davis is an epidemiologist and pulmonary critical care physician and associate professor at Yale School of Public Health and Medicine. And he's really leading amazing work at international that we'll hear about today regarding TB and HIV. He runs a training program focusing on improving delivery of evidence-based interventions in community and clinic settings, and really has also been on the front lines helping with our COVID response in the past year or so locally. So thank you so much for taking the time here to share your work. He wears many other hats as well. And Dr. Mary Armstrong-Hough, thank you so much for returning to us here at Yale for this talk. I know you spent some time here. Now you're at the assistant professor at NYU School of Global Public Health, trained as a medical sociologist and as epidemiologist of respiratory disease. And we're thrilled that you're going to be joining us and sharing more of the work that you've been doing together. We're also joined by Fadzai Munenzemwe from Johannesburg, and thank you so much for being available to answer questions. And please, anyone correct me if I've misstated your name. And Dr. Sheila Shinoy, thank you for joining as our discussant today and bringing your lens doing TB and HIV focused work in South Africa. So now I'll turn over to our speakers to share with us your work on interrupting HIV stigma in the household using home HIV testing offers in South Africa and Uganda. Take it away.
All right, let me just share my screen here. Can everybody see that? Great. Well, thank you so much for that introduction. And in particular, thank you for the opportunity to talk with you all today about these two sibling studies in South Africa and Uganda. And I'm joined by my colleagues, Fadzai and Luke today, but I'm going to sort of do the initial talk through some slides, give people some visuals, and then Luke and Fadzai are going to join in the discussion and in the Q&A towards the end. All right, so I call these sibling studies, and that's because they are studies that really are responding to the same problem. They're using the same scientific rationale. They're coming to some, similar conclusions about an intervention to evaluate, but they're taking place in two very different settings. And as you'll see, whenever we talk about stigma, the setting is really, really important because stigma is not just interpersonal, it's also intergroup. So I'm going to take a little bit of a different approach to the organization of this talk, and we're going to go through it more narratively. So first, we'll talk a bit about home-based HIV testing and its promise for integration into TB contact tracing. Then we'll talk about some of the issues that seem to arise when we attempt to integrate HIV testing into TB contact tracing and sort of identify the key problem here. And then I'll talk through our preliminary findings from Uganda and South Africa, respectively. And then in discussion and next steps, we can talk a little bit about what some of the similarities and maybe opportunities for a scalable, similar intervention might be, as well as some of the really important differences that arise. All right, so let's talk about home-based HIV testing. Nearly 40 million people worldwide are thought to be living with HIV, and more than 20% of them are not aware of their status. And that may be because they are unaware that they're at risk. It may be because they're unable to access HIV counseling and testing. But sometimes it's also because they are unwilling to accept HIV testing because of stigma for HIV. And layered onto that stigma for HIV is the risk of tuberculosis. About 40% of those with TB worldwide are also unaware of their TB status, and for similar reasons as for HIV. And critically, layered stigma for HIV and TB can introduce interlinked social and psychological barriers to testing for both of these conditions. So home-based testing is a promising approach to increasing test uptake and linkage to care for both HIV and TB. Because it can reach individuals outside the health system, it can eliminate the costs of traveling to clinics for testing, and it can offer testing in a familiar environment. And when I talk about home-based HIV counseling and testing, I'm talking about a very particular bundle of services. So this is testing that is offered in the home at no cost to the client. It is delivered by a lay health worker in private, and the results are delivered confidentially, even though the test offer is made in the home. Testing in the home is particularly appealing because it can reach so-called key populations, particularly men and adolescents, who might otherwise not be very inclined to test, either in a clinic setting or say through a testing ban. It also can save economically vulnerable households money and time, so it's appealing for that reason. And most important to me, there are recent data that suggest that home testing is actually associated with higher patient engagement and quality of life for those who test positive over time. And in general, across sub-Saharan Africa, rates of home HIV testing uptake are pretty high, which suggests that this is a popular service. A not so recent systematic review found that rates of HCT uptake would range from about 58% to 99%. And in the setting where we started out working in Uganda, which is what you see focused framed on the side here is Kampala, Uganda. In that setting, we see that house-to-house home HIV test offers have about 95% uptake. So they're very popular. So what's the problem? Well, there's a lot to like about integrating HIV testing into TB screening. Like I said, it can improve status awareness for these key populations. It can also add value to TB contact tracing. by making it more cost effective, as well as by strengthening its capacity to identify the highest risk contacts of a TB index patient. But layered stigma may reduce uptake during TB home visits. So there could be a sort of antagonistic relationship between offering these TB services and these HIV services during the same home visit. And there is some evidence for this. First of all, HIV test uptake is, I would say, disappointingly low during TB home visits. So our colleagues at the Orem Institute carried out a study a few years ago that found that only 35% of household contacts of TB patients who were offered an HIV test actually took up the offer. And we in Uganda found that as part of a randomized controlled trial that offered both TB contact tracing services and HIV testing, only 61% of those who were eligible actually accepted the test. And that's particularly disappointing because, as I said, in the same setting in Uganda, if you go house to house and offer HIV tests, the uptake is actually much higher. So there seems to be a need for strategies that can reduce stigma and increase HIV test uptake during TB contact investigation. And we came out of that with a question, which is, is it possible that these social interactions that are taking place at the same time as HIV testing sort of influence perceived stigma and test uptake? And our reasoning for this was that when we were offering HIV testing during TB contact investigation, this is a very social environment. The entire household has gathered for contact investigation, even if people are taken aside person by person for the HIV test offer. So let's talk about Uganda. We went about answering this initial question by doing a lot of formative research using both quantitative and qualitative data collected from Luke Davis's randomized controlled trial, which had been designed to evaluate an intervention that offered enhanced TB services at the time of TB contact investigation. So it was not an HIV testing trial, but nonetheless, in the intervention arm, HIV testing was offered in the course of TB contact investigation. And so we carried out a secondary analysis of observational data that included the sequential decisions of household contacts that had been offered that HIV test. And critically, we were able to go back and reconstruct the sequence in which those tests were offered and accepted or declined using timestamps from the forms that the community health workers filled out during contact investigation. We also looked at data from in-depth interviews that were collected from a stratified random sample of household contacts that had been offered HIV testing as part of that trial. And finally, we looked at data from focus group discussions with lay health workers who had actually delivered those HIV test offers, but who saw themselves as primarily involved in TB contact investigation. So we ended up interviewing 25 participants, contacts who had been offered HIV testing. 61% of them had accepted the test. 39% had declined the test. And we saw some interesting themes emerge. The first was that when we asked contacts very directly about how they reached their decision to test or not to test for HIV, the first thing they did was talk about other people's decisions. Now, one might see this as an attempt to deflect, but when we looked at the actual content of these responses, we found that most of the contacts were looking to family members for guidance about whether or not they should accept the test. So this is an example of a married woman who had initially declined to be tested. And so the community health worker had offered her the test, she had said no. And when her husband came in a little bit later, she perceived that he accepted the test. And because of that, she realized that there was really no reason for her to refuse. She changed her mind and she did go ahead and test. We saw a related theme emerge, which was that men tested because women asked. So this is another married couple. And in this case, the wife went first. And she had in fact, decided to test. And she very intentionally showed the consent form to her husband and told him that he ought to get tested as well. And what's really interesting is that every single one of the men in our sample who accepted the HIV test in their interview described some kind of a social interaction with a woman in their household, a wife, a mother, a sister, who encouraged them to get tested and cited that as the primary reason that they got tested that day. And then the last related theme was that observing another person in that household decline testing decreased willingness to test. So this young woman watched everybody in her household go before her. And while, again, the testing decision and the results are both confidential, she was able to discern that no one else had said yes to the test. And she told us that she was able to discern this because everyone went in order really quickly. And she knew that it would take longer if they said yes to the test. And so when it came to be her turn, she declined the test as well, because as she says, you cannot accept a test when the rest have refused to do so. So we went back then and we took a look at the quantitative data. So these are the data from all of the trial participants who have been offered, who are eligible for and were offered HIV testing during the TB contact investigation visit. And what we found was that people who had been present when the first tester or the first candidate in their family said no to the test were 4 times as likely to say no to the test as well. So what we're seeing in the quantitative data is actually exactly what people were telling us in the qualitative data, which is that when they're offered this test, they do sort of a quick calculation. Is it normal to accept this test in my household? Is this the right place for me to test? Are other people in my household doing the test? You know, I'm going to follow what they're doing. And so we see this very powerfully in the quantitative data as well. And I'm not going to talk through the focus group discussions because we have such limited time. But again, we saw a lot of alignment in the themes from those focus group discussions. The themes here are sort of that people don't so much test at home as that they test with their home and they test for their home. And what I mean by this is that testing at home is not something that people think of as a fully individual decision or as a fully individual act. Rather, they look around them to see whether or not it is typical in their home to say yes to the test. Is this an environment in which it is normal to test? And therefore, the first person who's offered testing in the home may help to establish testing as normative in the household if they say yes. And on the other hand, they might help to establish it as non-normative if they say no. Second, people seem to think of testing as testing for their home. And what I mean by this is that most contacts didn't seem to be testing just for themselves. Rather, in interviews, they would describe testing to motivate others in their household. So in the example of an older woman who said that she had no concerns about her own status, and she was in fact believed that she already knew her own status, but she wanted to set a good example for her grandchildren. So sometimes people would test to motivate others. Sometimes they would test to appease others, as in the case of men who wanted to communicate to their wives that they were trustworthy. And in other cases, people wanted to test merely to communicate their care for one another. So we sort of started to move away as we were moving towards an intervention that would try to address these low rates of HIV test uptake, move away from this idea of thinking of it just as an individual decision, an individual test, to thinking about it as something that is very much embedded in the home setting. And to do this, we looked to sort of some classic social psychological literature on perceived norms and on small group dynamics. There's literature that has suggested that underestimating HIV test uptake in one's community is associated with not testing for HIV, which we read as showing the importance of perceived norms. If you perceive testing to be normative in your primary group, then you're going to be more likely to test yourself. Similarly, there's a very long tradition of literature on conformity in small groups that suggests that observing others' behavior shapes not only our perceptions, but also our judgments and our subsequent behaviors. And so these sort of household dynamics, the order in which people make decisions, and in particular that decision of the first tester, can be very important for shaping the dynamic of the testing decisions. So from this, we identified sort of 3 big asks from a new delivery strategy. We needed a delivery strategy that would establish HIV testing in the home as normative, even during TB contact investigation. A strategy that would establish testing as beneficial for the household, not only for the individual, and one that would maximize the acceptability of the test. So we went about trying to establish testing as normative in 3 ways. First, by sequencing test offers in a way that we thought would optimize the likelihood that the first candidate would test. We tried to maximize opportunities to share affirmative decisions. So if somebody in the household says no, we want to try to mask that. If someone in the household says yes, we want to give them the option, at least, to share that affirmative decision with the rest of their household to try to show how normal it is and acceptable it is to test at home. Oops. We try to establish testing as prosocial. And by that, we mean that we try to establish testing as something that had benefits for everybody in the household, that it was not something you would do because you were individually worried about your own status or anything like that, but rather that something you would do in order to model good behavior for the rest of your home. And then finally, we tried to maximize acceptability. We did this by deciding to move to a less invasive oral HIV testing modality. And also by engaging in iterative participatory research to adapt the invitation scripts and the entire experience to these households that have recently received a TB diagnosis, which we know can be particularly vulnerable. Their houses under stress. And so this is what that delivery strategy looked like when we mapped it out. We kind of had those 3 asks. And so we came up with a plan to offer HIV testing, but instead of just going in there and offering it at random to the first person, or as is commonly done, to just sort of unthinkingly offer it to the oldest man with the assumption that they were the head of household, instead we decided to think very carefully about the selection of that first tester. And we iterated through different ways of doing this. What we started with, though, was to select the oldest woman in the household, because our quantitative data showed us that while such people may be less likely to be living with HIV without being aware of it, they were the most likely to say yes to the test. So that first element is selecting a likely first tester, framing the offer to them in prosocial terms. Sorry, my slides are jumping around. So introducing the offer by saying, there are many benefits to testing, but our research has also shown that if you decide to test yourself, it may empower others in the household to feel comfortable testing today as well. We also use default framing in that test offer. And as I mentioned earlier, we used an oral HIV test. If the first tester said yes to the test, they were privately invited to share their decision, but not their test results with the rest of the household. And if they said no to the test, they were held, just an extra 15 minutes, the amount of time it would have taken to complete the test, to complete a survey and answer some questions about it, just to try to mask their negative decision to the rest of the household. So the next thing that we did was go through an optimization process. And so what we did was we took that prototype, that very abstract map that I just showed you, we translated it into some actual procedures, and we created what we called a prototype, and actually administered that prototype to, I think we did about 15 households in the first round. And then we did intercept interviews with household members who've been offered the HIV test as part of that prototype. We also carried out a focus group discussion with the lay health workers who had delivered it. And then we used a very sort of structured, formal process called nominal group technique to discuss together as an investigative group what those interviews were telling us about how we needed to further adapt this intervention prototype or this delivery prototype for the setting so that we could maximize acceptability and also effectiveness. We went through this in 3 rounds. It took about 4 months for us to do it. And then we ended up, I think, administering it to about 56 households. At the end, we carried out an impact evaluation to evaluate its acceptance and its impact on stigma, which I'm not going to talk about as much today because of time, but I'm happy to talk about in Q&A. The result of that was that of 181 people who were encountered by community health workers, 148 of these household contacts were eligible for HIV testing, and 98% of them accepted the adapted new delivery strategy. So that's compared to 61% who had accepted during our previous trial. And I want to add the caveat here that this was not a randomized controlled trial. We'll talk more about the next steps for that at the end. All right, so
Mary,
yes.
May I just interrupt? There's just one clarifying question in the chat around the nature of households that you're discussing, couples, large households, nuclear family households, if you don't mind answering that as you continue. Thank you.
Yes, such an important question. Thank you for that. So the households were determined according to the question, are you sleeping under the same roof? So there did not have to be any kind of, there didn't even have to be a social sort of kin relationship at all. So it could be couples, it could be nuclear families, they were often extended families. And in some cases, they were actually people who were roommates. So for example, boda drivers, the guys who drive bikes and move people around Kampala, sometimes they live in shared households of 9 or 10 people, and they would be considered a household as well. There's a very, very diverse group of people who are calling households here. All right, so let's shift to talking about South Africa, moving to a very different setting. Now, we were excited about the preliminary data that was coming out of Uganda, and we really wanted to work with our colleagues at Orem to try to identify ways that a delivery strategy might address the problem that I had raised earlier, which is that during TB contact investigation in South Africa, only 35% of those who are eligible for HIV testing actually accept that home-based HIV test offer. And so, we thought this is the same problem, the same rationale, should apply. So let's go in and let's do some formative research in collaboration with everybody at Orem to try to understand, are there the same barriers and facilitators in the South African setting? Might we be able to develop a new delivery strategy that would be appropriate for South Africa as well? And gosh, wouldn't it be great if, what we found was that there was a single widely scalable solution. So those are the idealistic thoughts with which we went into collecting data in South Africa. And, Luke and I, with support from CIRA, got to travel to Johannesburg to meet with Fadzai and Kavi and Salome for a few days to go over this whole research plan. And one of the first things that we realized in those 2 days of reading was that we had to slow down, take a deep breath, and do more formative research, which I feel like we should probably make a poster of, like social scientists in HIV research should make a poster like that and put it on our front doors. Because, we had sort of gone into this hot and we'd said, oh, we have this, this delivery strategy design that we've been working on. Let's go straight into doing this iterative prototyping based research. But, even as we started going over the focus group discussion guides and the interview guides, our colleagues in South Africa said, hold on, this is a really different setting actually, and we might need to think about this differently. So we backed up and we did formative research. We collected observational data as part of a pilot program to offer HIV testing as part of TB contact investigation. We then collected intercept interviews from household contacts that had been offered HIV testing during those TB home visits. And we carried out a focus group discussion with the lay health workers who were primarily research assistants, I should say, who delivered those HIV test offers. So we sort of, we went back to square one and we started with the whole process again, just like we had in Uganda. So 34 index patients were assessed for eligibility. 19 of them were enrolled, and the lay health workers were able to visit and carry out TB contact investigation at 19 households. At those 19 households, they were able to offer HIV testing to 33 household contacts, 61% of whom accepted the HIV test offer. And I think that that's actually sort of notable. There, again, in that earlier study in South Africa in a parallel population, only 35% had offered the HIV test offer. In our very small pilot study, we were finding that 61% accepted the offer. And part of that may be that this was a study that was focused on HIV test offers. So there may have been different sort of prioritization of the HIV test offer in our study compared to the previous one. We then interviewed, we purposely selected 20 of those household contacts for interviews, and 9 of them had accepted the HIV test offer, which is a little bit more than the overall proportion who had accepted the oral HIV test offer. So there were some interesting themes that emerged in these intercept interviews, and some of them were similar to what we saw in Uganda. The most common theme and the most frequently repeated within interviews was that it was better to get bad news at home. So, this is a man who did accept, and he's describing how he thought through the process and how he would weigh testing at a clinic versus testing at home. And, in either case, it's not actually a very pleasant prospect for this man, but he feels like if you get bad news, then he would rather be at home where he could sort of gather himself and, as he puts it, prepare himself for the road ahead, what you're going to face. We did see that some contacts said that they tested to motivate others. So this is an example from a woman who accepted the test, who apparently told the lay health worker to leave her result on the car so that she could motivate others in her household to take the test. She says, because I know they're not comfortable when you're talking about this thing. So I told them there's nothing wrong about testing. They need to know their status because I know now they're not comfortable, believe me. So again, this is very similar to the theme that we saw in the interviews in Uganda, where some people, particularly women in the household, would test primarily to try to motivate others in their household or to try to model what they saw as a healthy behavior to the rest of their household. But this theme was much less common. And again, this is, we purposely sampled, so numbers don't really necessarily mean anything here, but this was a theme that was almost overpowering the Ugandan data, whereas only 3 of the 20 contacts that we interviewed in South Africa raised this issue. And critically, while some contacts in South Africa told us that they tested to motivate others, no contact told us that they tested because they believed that someone else in their household had tested. So we didn't see that very strong pattern that we've seen in Uganda of men saying that they had tested because they perceived that a woman in their household had tested and that it was expected of them as well. The third big thing that we saw was that even though most contacts said that they felt that their family was supportive, stigma in the community was perceived to be a real threat. So, when we probed them about concerns about either HIV testing itself being stigmatized or HIV being stigmatized, we didn't, we saw a lot of themes about, well, even if my family is supportive and I could share my status with them and I would be comfortable here, it's still something that's really stigmatized in the community and that we would need to face. So, sorry, my slides are sort of lagging. Thank you. All right, so this is sort of a busy slide, but just to give a sense of some of the differences that we saw here. In both Uganda and in South Africa, in the formative data, there were sort of three big themes, and those were, fear status awareness, preferences around the home test, and then the themes that I presented around the household social dynamic. But where we saw real differences was in this theme around the household social dynamic. So in Uganda, we saw strong evidence of prosocial reasoning among many of the contacts who were interviewed. And we saw this in the quantitative data as well, that people were more likely to test if they believed that their own decision to test was going to empower others in their household. We saw that people were more likely to test if they had seen people ahead of them test. We saw much weaker evidence of this in the South African data. So while some tested to set an example, no one tested because they believed that someone else in their household had tested. And one of the reasons for this might be that in contrast to the Ugandan participants, most of the South African participants said that they did not discuss health matters at home at all. So, I think this leads us, not quite where we were when we came in hot to the South African side of the project, where we thought, oh, we're ready to go. We're gonna, we're gonna take this prototype. We're gonna iterate it. I think that what we've realized is that the prototype itself actually needs to be readjusted for South Africa. We're still seeing, good evidence to suggest that prosocial reasoning might increase uptake of HIV testing, TB contact investigation. We're seeing some evidence that framing testing as a family, as normal and as routine might be helpful. But we're also seeing that household dynamics are so different in South Africa that these components just might not be sufficient to shift perceptions of stigma within the household or to shift those test decisions. And so, what we're talking about now, or thinking about now, is adding another component to this. And I have labeled this the Bring Health Home component. And it comes out of the observation in our formative research that no one really seemed to think of the home as a place where health matters were discussed. The vast majority of participants told us that they never discussed health matters at home. Even those who said that they trusted their family and thought that they would be supportive about HIV testing, they said it's just not a thing that's talked about in the home at all. And so there's a need for opportunities to discuss health matters more in the home, and therefore sort of normalize the idea of even making a decision to test at home. And so that feeds into the next steps for these. I'll start with the next steps for South Africa, which is, I think we're ready at this point. We finished the formative research. We have an idea about how we would reimagine a delivery strategy prototype for South Africa. And the next step is to go through this participatory prototyping process that I described for Uganda, where we go through those 5 steps and we iterate through 3 different rounds in order to try to adapt the delivery strategy to the needs and preferences of people who are actually undergoing TB contact investigation. We're hoping to do this in about 30 households who participate in contact investigation. And the measures that we'll be looking at and optimizing for would be acceptability, feasibility, and effectiveness at increasing test uptake, just like we did in Uganda. In Uganda, where we're a little bit more ahead of the game, in part because we had a lot more lead time before COVID hit, we're actually at the stage where about a little over a week ago, we started enrolling a multi-center household randomized trial. And that trial will enroll a total of 152 TB patient households with at least 304 household contacts. It will evaluate usual care versus this norming intervention, which is to say this new delivery strategy that we've developed. And it will evaluate as a primary outcome oral HIV test acceptance, and then as secondary outcomes, HIV diagnoses, linkage to care, and change in perceived household stigma for HIV and TB using a pair of parallel stigma scales that we developed specifically for this population. All right, with that, thanks so much for listening to this. I'm sure people have a lot of questions. And I just want to emphasize again that Luke and Fadzai are here to participate in the discussion and the Q&A. So don't only direct them at me. I am just the mouthpiece for this project.
More than that. Thanks, Mary.
This was a fantastic presentation, so clear and beautiful slides. I just want to say too, but such important work. And thank you so much for sharing all this with us. I'm sure there's lots of questions. I have one too, but I first want to give Sheila the opportunity. I don't see you, Sheila, this second on my screen, but I don't know if you have some comments. There you are. Comments, questions that you want to bring.
Thank you, Jen, and thank you, Mary, Luke, Fadzai, for this presentation. This is fantastic. I'm completely fascinated by this work. For those of you who may not know, I've spent a lot of time talking with this team about and my interest in community-based strategies to improve the TB and HIV cascades of care. And so this is absolutely vital work that you're doing. So thank you for that. I wanted to understand a little bit more. I completely see the differences between Uganda and South Africa. And when you were presenting some of the Uganda data, I was thinking, I was like, that's just not been our experience in South Africa, and so as you presented toward the end a little bit more about the South Africa findings and how different they were, I felt better. I was like, oh, no, I felt validated to a certain extent. I do think it's so important to realize that there's different contexts. And I wanted to ask a little bit about the cultural norms around general decision-making, not even necessarily health decision-making or HIV specifically, but just the cultural norms that exist in Uganda, whether or not there is that kind of diversity in Uganda that we see in South Africa. The different provinces, there's different tribes that have very different cultural norms. I know your experience in South Africa was largely based in Gauteng, so the Xhosa population, in the Zulu population in KZN, where I have more experience. It's a very strong community-based and home-based culture. Everybody knows everything that's going on in the community. There's a very tight connection to one's home and culture. And not to say that there's not stigma, but I think things are very, outside of the HIV stigma, things are very closely discussed in the home. And so I was wondering if you could comment a little bit about just what the cultural norms were, what the diversity is in Uganda in comparison to South Africa, that might perhaps explain some of the I know you didn't have as much time to go into all these nuances, so if you wouldn't mind.
Yeah, so maybe I can talk a little bit about Uganda, and then Fadzai can chime in and talk a little bit about the population that we were working with in South Africa. So in Uganda, the population that sort of were targeted in the study are people who are living in Kampala, which is the capital city. And what we see is a lot of diversity in terms of the household's tenure in Kampala. They move there from a village. There is the migrant labor dynamic is not as strong in Uganda as in South Africa, but it's still common to go back and forth between one's village and the household in Kampala. So there's some going back and forth. But I think that we actually saw in these intercept interviews a lot of diversity in how close-knit these households were, to what extent decisions were made communally versus individually. And that comes from the underlying diversity of what we call the household. So, like I mentioned earlier, some of these households are nuclear or extended families. Other households are thrown together, they're almost more like roommates. And so there's not necessarily going to be it's not necessarily going to be normal for folks to sit around and discuss their most personal health decisions in that setting. Within the family-based households, though, what we saw was that decisions were not necessarily made communally, but there was a lot of social influence within the household, and that particularly older women seemed to have a lot of influence in the household, that, you know, people sort of looked to them, people wanted to please them, you know, people wanted to please their mom and their grandma. And you know, so that seemed really influential, but it wasn't necessarily, as has been found in other studies, it wasn't that it was just a household decision to test or not test for HIV. It was not a purely communal decision. There was sort of some give and take between the individual and the group, as you know, as a result of discussion. Fazai, do you want to comment a little bit about the setting in South Africa?
Yes, sure. So in South Africa, it was very different. The area that we were working in and where we targeted and looked for our participants was in Gauteng and Johannesburg, which is really the hub, the economic hub of the country. Gauteng is very populated, and you get a lot of people coming to Gauteng, particularly Johannesburg, for work. So a lot of people in these households then may not necessarily know each other very well. For example, maybe an aunt may live in Johannesburg and I live in KwaZulu-Natal, and then my aunt will look for a job for me, and then that's how I end up living with her. So then because of that, there weren't really strong relationships between the household members. And that is something that we see quite a lot in the high density areas in South Africa, and especially in Johannesburg, where people are living together, but that closeness, and there's not much trust as well. There's a lot of trust lacking, especially when it comes to the younger generation and the old generation. The younger people felt like, you know, they would be judged, and, you know, they're really not comfortable to discuss matters around, especially HIV testing, because maybe then they'll think that, you know, my elders will now think that I'm going and sleeping around, or I'm taking part in dangerous activities and things like that. So that really is the sort of population that we were working with. Thanks.
No, that makes perfect sense. Thank you, Fazai. I completely agree. And I'm wondering if there's also an urban-rural component to this. That would make a difference in what results you saw from South Africa. I'm not sure about Uganda, but definitely have experienced a lot of internal migration, as Fazai pointed out, for employment opportunities, particularly from more impoverished rural areas to urban settings, and so definitely influences the composition of the household. Thank you.
Yeah, that's actually a really interesting point, and I'm going to just briefly share my screen really quickly because I was having trouble with my slide transitions, and so I'm not sure that we got to look at this for long enough, but I just wanted to bring up this question of, like, you know, how important is the rural urban difference here? And one of the things that we saw strongly in the Ugandan data was that people were really concerned about perceived stigma for HIV testing within their own households, but they didn't seem concerned about HIV-related stigma in the community. So like that's a really important difference, that they're not worried. In Uganda, the participants weren't worried about their friends judging them for living with HIV. They were worried about their household, that like their father thinking that if like their father had said no to the test and then they say yes to the test, that then their father is going to think that says something about their risky behaviors, right? It labels them as a risky person. And I just wanted to like pull up this slide really quickly and mention it again, because stigma is constantly implicated in testing hesitance, in testing for HIV, you know, whether it's at a clinic or in a household or anywhere else. But there are sort of different types of stigma, and that has to really like impact how we design interventions to mitigate it. And so in this case, like in Uganda, we were hearing in the interviews that it was perceived stigma within the households that was really driving people's decisions to test or not test for HIV, in this very specific setting. But that doesn't mean that that is going to be what influences overall decisions to test in other settings. Or, for example, when we move to South Africa, if people are more concerned about stigma in like their wider community, like being negatively labeled by their wider community than by their very closest relatives, then that's also going to change the sort of incentive and disincentive structure for testing for HIV in the home.
Thank you. I had lots more questions. When we've done testing at the household level, we have very hard time finding men, particularly in rural KZN, that you guys have had a very different experience. Questions about the interaction between the TB testing and TB stigma and HIV stigma. But I see there's lots of questions. And so I want to defer to them, if that's okay, Jen.
Thank you, Sheila, so much. I think Gamgee had his hand up first. So Gamgee, please take it away.
Hello. Thank you very much for your presentation. And I'm from Ghana, and I'm also interested in HIV self-testing, especially in homes. I asked the question earlier on in the chat about households. For me, coming from Africa and how we came to describe the household made me a little bit shaky in terms of what that means for interpreting the results, to be honest. For instance, people living in the same space versus who are actually family and all these other dynamics. I think when we move forward, we want to get some kind of clarity in terms of who a household actually means. But I'm happy that as we move on, you start talking about the trust issues, people living in the same space, not trusting each other, and how the decision-making process comes in, right? If you look at some other research, if you are discussing couples, for instance, we can see some dynamics there, but people that are also just roommates for some reasons of migration is a whole different kind of discussion. And then when we come to nuclear families versus extended family, these are all like really, really huge context that for me was kind of tied in together, and I wasn't very clear with that. But then, and I was also concerned about the stigma piece, right? That also ties to the trust and all these other pieces that we are discussing. So it's kind of really compounded. So when we look at stigma in the African context, or even for those of us in West Africa, to be much more specific, I don't think even for me, who does work on HIV testing, I'll be very comfortable doing that with my household. In actual definition of household in the African sense, which include me, my mom, my brother, and that kind of context. So that's why I was really confused about where we are going with this discussion of household and the kind of intervention. I wanted to hear more about how did you intervene within these households to work around stigma before offering these HIV testing options, or there was no any other intervention around stigma before you give it out, because that would be really a huge barrier, even though it may not be the only barrier. When it comes to testing in African homes, I'll be afraid, like somebody said, they left it on the car, right? She left it on the car because it's negative. I can bet that if it's positive, she's not gonna leave it for anybody to see. But then what happens then within a household where some people shows their results and others don't? What does that mean for the household? So what happens after the testing? That's another question. And how, again, do we link them to care without actually affecting confidentiality and all these other household dynamics that comes with it? I'm sure it's like a long question, but I'm just trying to unpack stuff there.
Thanks. I could try to tackle that. It's a really good question, Gamgee, and I think what you're saying is households are really different, and you're trying to give sort of more of a standard intervention. How is that going to address many different types of households, if I understood you? And I think it is a very complex scenario. I think our overall approach has been to try to identify what are some of the common factors that you might be able to modify in order to increase the likelihood that people would engage in healthy, positive behaviors and not do things that would increase stigma. I don't know that we can sort of address every type of dynamic that exists, but I think too often we think about trying to develop interventions that are sort of one size fits all. And by designing these interventions so that our community health workers have a greater sense to what are some of the dynamics in the household, it may give them different strategies that they can apply in terms of how they present things to increase the likelihood that people would say yes. And so just a lot of our work has engaged with that kind of idea of, how do you create demand rather than just sort of offer something that people don't really want. And it'd be great to talk with you more because obviously, we saw differences between South Africa and Uganda. There might be big differences, say, with Ghana and other countries. And hearing that perspective would be really, really useful to us. So maybe we can reach out and have a chat with you at some point.
Yeah, I think these are such important issues to raise. And as soon as we start talking about stigma, the small group setting really, really matters, and how we define a household really matters. But what counts as a household and what counts as family is so different in different settings. And the dynamics among those people are so different in different settings that I think it presents a real challenge for us actually for developing scalable interventions and strategies. And the best strategy may be a differentiated delivery strategy, right? Like sometimes every situation is different and we have to respond to that. I did just want to comment on, I like the questions that you're asking about, well, like, how are you actually intervening on stigma? And that's something that I didn't feel like we quite had enough time to talk about in the presentation. We still don't have enough time here, but I just wanted to pull this up and give you what our conceptual framework was for how we understand stigma. We think about stigma as a process, and that's why we think of this as an interruption. And that prototype that we described, it's really trying to act on two different things. First, the distinguishing and labeling stage of stigmatization. So we're removing the opportunity for people to be labeled as testers and have that be associated with negative attributes. We're actually seeking to very proactively associate testing with positive prosocial attributes, right? So you don't test because you, as they say in Uganda, don't trust yourself, right? You don't test because you think that you did something risky. You test so that you can model good behavior for the rest of your household, right? Testing is something that a leader does in the household. And so, we're really, as we thought through this prototype, what we were doing was trying to intervene on these first two steps in the stigma process and try to actually interrupt that dynamic before it has a chance to really get going in the context of a TB contact investigation visit.
So I see we're at the top of the hour. We could use many more hours to have ongoing conversation because this is such important work and so many different directions and things to think about here. But just want to be respectful of everybody's time. Thank you all for such a fabulous and thought-provoking presentation and really, really important work. And hopefully you'll come back and share with us the next steps as you have launched your trial. Congratulations on that. And we'd love to hear more as it unfolds. Thank you, everybody.
Thank you, everybody.
Thank you, everyone. Thanks so much.
Thanks so much, Jen, Denny, and Sheila. This is great. Thanks, Fud.